Welcome to Care Crafting Connections. Today, I have a special guest, Dr. Natalie Sanders. I like to call her Dr. Nat. Dr. Nat will be here to discuss how to age with dignity, the difference between hospice and palliative care. I'd like to welcome Dr. Nat. Dr. Nat, how are you doing today?
I'm great. Thank you so much, Shannon, for inviting me.
Yes. Please tell us your history, everything about you and how great you are.
How much time do we have?
We got all day.
I'm Dr. Natalie Sanders.
Mm-hmm.
I am an internal medicine physician.
Mm-hmm.
Basically, I take care of adults. Mm-hmm. And over the last 20 plus years, I've done a lot of elder care. Mm-hmm. And for the last 15 years, I have focused specifically on hospice care.
I would like to discuss how we met.
Okay.
So Dr. Sanders and I were initially introduced, I think you were through a referral.
Wendy,
yes. Yes, we met through Wendy. It was a referral. And then we started discussing and we realized we were in the same industry. And I was blessed to help her find placement for her mother.
Absolutely.
Yes.
Talk about a blessing.
Yes.
It was a major, major blessing. I moved my mom out to L.A. from North Carolina. She had dementia. And we had previously discussed it, even though, of course, she didn't remember the discussion.
Correct.
We had previously discussed that I couldn't have her live with me, but I would find a place that was very suitable for her. And so initially we started with an assisted living facility, which was amazing. I like to say it was like a cruise ship on land.
Oh, right.
She had gone to, by the end of 3 years, she had gone to every museum in L.A. twice.
Wow.
And I had been living here 30 years, and many of them I hadn't even gone to once. But they took great care of her. And she had a stroke. And with that, she needed a higher level of care and more one-on-one attention, which couldn't be provided without additional supplementation of caregiver support at the assisted living facility. And I came to you and I said, Shannon, help me find a boarding care, or as we say in the industry, an RCFE, residential care for the elderly type of facility. And you made an absolutely amazing referral. And I like to say that the Laredo family that owned that particular facility and two others took care of my mother like a goddess.
She does.
And they also took care of me.
You're right. Because I wanted to discuss the emotional aspect of when you have to decide to place someone. I know it was difficult for me, especially for my mom, because when people tell you that, it's still your parent, and it's easier for us to understand because we come from the industry. We say it so much, but when it's personally you kind of finally figure out how it feels, and then it impacts you a little differently. How did it make you feel to make that tough decision?
Well, actually, I knew it was the best decision for her. I was really happy when she said she wanted to stay in Los Angeles and not go, because she had come out for a vacation.
Right.
And so when she said, I don't want to go back home, I was a little surprised. And I had actually hired some caregivers to help care for her while she was here for her vacation. And I pulled them all aside and said, my mother says she doesn't want to go back to North Carolina. Kind of ask her in your kind of way over the next few days to make sure that this is really
what she wants,
something that she wants, and not just something she said that one day. Because sometimes patients with dementia will say something, comes out of left field, and it's not consistent.
Right.
And so once I was convinced, I began looking for a place. I think part of the reason it wasn't so difficult was because I am in the industry, and as some of the elder care work I had been doing in the South Bay, I was going to assisted living facilities, boarding cares, as well as nursing homes, seeing some of the homebound patients that I was charged with through Kaiser. So I understood what could be offered at each type of facility. Also, because my mom had been 3,000 miles away and we saw each other maybe 4 or 5 times a year, she wasn't like she had been living in my home and had been a part of my daily life every day. So I think the idea of her going into a facility wasn't really much difficult than me putting her back on a plane and sending her back to North Carolina.
Right.
I think the big challenge for me was when I had to move her from assisted living to boarding care, because that was also a signal that her level of functionality and her level of cognition was worse. And there's a lot of emotion attached to that because she had been, Wonder Woman or a super mom, had, essentially raised me and put me through college, medical school, and had been a big support for me.
Through the
So
process.
then when you start to see that even though the body is still there, but the mind is not, that is a grief. There is a grief process that happens there because you start to lose that parent.
I understand. So for the audience to understand the difference between assisted living and boarding care,
Yes.
people kind of lump those together.
Oh, no, they're very different.
They're very different. Assisted living, you have to be a little bit more higher functioning.
Yes.
You have to provide, at least be more cognitive and not wander. There's a lot of risk involved. And then boarding care is more a higher level of care.
Yes.
And I think in our
More
industry,
one-on-one care.
more one-on-one care, because he's usually in a home setting.
Yes.
And then it's about 6 beds, and then it's more intimate.
Yes.
So I think that's important because in our industry, people just think skilled nursing, assisted living, and it's all the same, and it's not. And there's a variation of different care. And I know you have experience and also in palliative and hospice care.
Yes.
Could you tell us a little bit about that and what it is? Because people hear those words, they shy away from it, and they really want to
freak
say,
out.
yes, they do
They
freak
think
out.
death is tomorrow.
Tomorrow, yes. So can you tell us, because if you even offer hospice, 8 out of 10 times you're going to get screamed at.
Okay, I'll mention to you that even when her geriatrician said to me, I think we should put your mom on hospice, and I kind of went,
Excuse
Are we
me?
there yet?
Yes, right.
Are
right.
we there yet?
Right.
He was right on the money.
He was.
He was right on the money.
And it's funny how we were talking about that previously when it's your loved one. And when they make these suggestions, it hits you harder because you know what the term is, but you have to kind of digest it and see if it's coming from you're just working through all these different emotions.
Exactly.
So I think it's important.
Exactly.
Yes, but go ahead. I'm sorry.
But basically, hospice care is a service that is dedicated to providing comfort, care, maintenance of dignity, from wherever the patient enters the service through death.
Okay.
And the beauty of hospice is that it can be provided anywhere.
Right.
It can be provided in a nursing home. It can be provided in the assisted living facility. It can be provided in the boarding care as well as in the home. And I actually see patients in all of those settings.
Okay.
Tomorrow, I'm actually going to a nursing home to see a new hospice admission. Monday, I'm going to a private home after I leave a nursing home doing SNF work to see a new hospice patient in their home. And the care is interdisciplinary in that it's the doctor, a registered nurse, social worker, and spiritual care coordinator. And that spiritual care coordinator, it's not so much about religion, but it's about nurturing the spirit within the individual and supporting the family. So hospice is not only good for the patient, so to speak, but it's also great for the family because the family knows they have support.
So do you have to have an end-of-life diagnosis in order to be? You do have to have an end-of-life.
And actually that end-of-life diagnosis is something that the referring physician and the hospice medical director has to certify. And Medicare has strict guidelines.
Okay.
So it's based on the actual primary diagnosis, but also any other medical conditions that the patient may have.
So you don't necessarily have to have 6 months or less to live.
We have to certify to that, but we certify in vague words like more than likely, if the condition follows the usual course, this patient may not be alive in 6 months.
Okay.
And at 6 months, that's actually when Medicare requires the first doctor eye to eye, face to face, as we like to call it, visit. Because if they're still there at 6 months, they want to understand why. And then after that, every 60 days, the doctor must see them. There's already a schedule for the nursing and psychosocial and spiritual support.
So if you could compare the two because for me, I always promote assisted living, especially if you have a busy schedule, when you have a parent, because it's a lot, especially a person that has higher acuity of care if they have dementia. How do you coach the families to decide? Do you ever make suggestions as a physician to say, I think this is best?
Unfortunately, I hate to say it this way, but it's just the honest truth. It's really all about money. What can you afford?
Yes. Yes.
What can you afford?
Right.
If you have more funds, assisted living is fantastic because it's kind of like sending your loved one to a hotel camp. They get 3 square meals a day and other activities. If they have good cognition, they may be able to come and go from the facility independently. If they have compromised cognition, there are facilities that still are really great, but they can't get out the front door. They have to be you have to be buzzed out, right? So they're secure. And even within some of those communities, there are levels of care. Maybe someone only needs assistance with some of their personal hygiene things, but they can feed themselves. So that may be, and they can even take their own medications, then that's a level of care. Then if someone has more needs, there's a higher level of care, so there's more cost.
Got it.
And the costliest would be if they are actually non-ambulatory and not able to feed themselves.
So as a physician, when you see someone that a lot of times in our industry, they want to keep the parent home.
Okay.
And you see that they need 24-hour care and the family's like, no, we want to have caregivers. I always explain, just because you have caregivers, you still need support. So they think that just bringing in caregivers and then that's it. What have you seen?
Well, I tell them honestly, okay. And is anybody in the family going to participate in the care? And if they say no, I say, okay, then you need to hire at least 4 people because you need a schedule for them. And you always need that kind of, you might say, why not just 3? Well, you always need somebody in reserve because somebody's going to get sick. Somebody's going to call off, right? You're right. So, so you need to have 4 people that you've interviewed, that you trust. And of course you hire them and they may not work out. Maybe your loved one and that person don't get along. So anyway, but you hire these people and make a schedule and they do what is required.
And what is the risk? Because what I've noticed, you're still involved.
Yes.
Even though you hired the 4 caregivers, you still have to be involved. What does that level of involvement look like when you're in the home?
Yes, you still have to be involved. You have to manage the schedule. You have to make sure that the caregivers are actually, if you're going to let them give medications, you need to feel comfortable that they can give the right medications at the right times. Otherwise, that becomes your responsibility.
Right.
Are those caregivers going to provide? Are they going to make meals, or is the family going to make meals? You have to negotiate all of that. So it's still a lot of work.
It's still a lot of work, and it's more intricate than people think because they think that they hire the caregivers, they're professionals, but they still need to be managed.
Yes.
So as to making that decision of going to an assisted living, you then see that that's the assisted living's responsibility, and you could kind of enjoy your parent a little bit more.
You can, yes. And that was, for me, that was also important. I wanted to be able to be the daughter who
Right.
just happened to be a physician.
Yes.
I didn't really want to manage the care. I
Like, I don't want to argue with her about what she needs to take, what she
I
has
was
to
very
do.
happy that
Right.
she had a geriatrician
Right.
that we knew and had been engaged with and I trusted.
So a geriatrician, can you explain what that is? So that we
Okay,
can
that's
know?
basically a doctor who takes care of people over the age of about 60. And they are scarce.
They are.
They are scarce because there's such demand with our aging population. Most geriatricians do just a consultation type of practice where they will see you for a specific issue like medication management or cognition evaluations, but they may not do the primary care. I was lucky that we had a geriatrician who did it all, and he had designed his practice in a way that he did have office hours for ambulatory patients, but he also was the doctor, kind of like the medical director of several assisted living facilities. When we chose our assisted living facility, I had no clue that he was involved.
Wow. So
But
it
I was
worked out.
pleasantly surprised
Yes.
because then he could see her in that environment, particularly as she began to have some ambulation challenges, and then I didn't have to literally, come and get her and take her to his office. He could see her right there in the assisted living when he was making rounds on other patients or when she was in the rotation to be seen.
So it's more convenient in that setting because it limits, you don't have to worry about the medication management. You don't have to worry about the doctor's appointments, the meals. Like you said, you could actually be the daughter. Because when we try to educate the families about their decisions, there's such a strong stigma against assisted livings or skilled nursing, where they
Well,
feel
now, skilled nursing is different.
no. Skilled nurses are different, but the objective of the skilled nurse is to rehab and
Yes.
go to a lower level of care.
Yes.
It's not supposed to be a long-term
Exactly.
placement, and people feel like that should be a long-term placement, but the quality of care, the quality of life is not supposed to be in a skilled nursing.
You are correct.
Right.
And that's one of the things that I talk with my inherited or my new custodial residents.
Correct.
Because they have come from a skilled setting where they have been getting rehabilitation 6 days a week,
Correct.
maybe multiple disciplines, and they've plateaued, or as I like to say, you flunked out of rehab.
Right.
And that's how you got me.
Gotcha. We need to have this tough conversation. Right. Understood.
And custodial care is really that. The facility is the custodian of the person. They feed them. They do get their medications administered by licensed professionals.
Correct.
And because the custodial care is usually in the same setting as the skilled care, they get all the other benefits of skilled observation, such as skin evaluations and screening quarterly for changes in functionality. So that is a benefit, but you're right. The quality of life is not the same. If I had my druthers, I would not live in a custodial facility.
Absolutely not. It's more
If
of a
I could
higher.
afford it, I would go to assisted living. And if I couldn't afford it, I would. If I couldn't afford assisted living, then the next, and could not be in my own home, the next one would be to go to residential care for the elderly.
Because it's very what I've witnessed when we have to have that tough conversation of them living in skilled nursing, they're afraid to go to the lower level of care because they're thinking that they won't get that 24-hour support. And even though they may not have as much staff as a skilled nursing, but you still have that level of support in a RCFE. So it's been very difficult, especially for the custodian patients, when we're trying to explain to them to make a transition to a lower level of care, they don't want to leave. And I'm sure you've had that have that situation where they don't want to leave because they're comfortable,
Right.
and that's become the part of their home
Right.
in the skilled nursing setting.
And there's still that whole financial aspect of it because assisted living costs more than the residential care for the elderly, and most of that is not paid for by Medicare.
So they have a program now, the assisted living waiver.
Yes, they have the waiver, and the wait for those waivers is a minimum of 3 months after you have gone into custodial care, and there's a lot of demand for it.
It is a lot of demand, and there's a new program called Community Supports. So the managed care plans are now paying for assisted livings as well, because it's such a need, and assisted livings are so expensive, where the average person that has worked doesn't have the financial means to pay maybe $6,000 to $8,000 a month for the level of care that they need. So now they're seeing that the insurance is willing to pay the assisted living versus living in a skilled nursing at a higher cost. So it's more talk around that, and there's more programs to kind of subsidize that level of care to assist with the cost.
The psycho-emotional benefit of being in assisted living versus in a nursing home is such that with assisted livings, if you have some semblance of ambulation, for example, maybe you need to use a walker, but if most assisted livings now will have a van, and they will take their residents on outings.
Correct.
And dollar matinees.
It's more socialization.
Yes. So there is, yes, and then they have activities.
Some have happy hour.
Yes, that too. That's true.
Some have happy
That's
hour.
true.
You can enjoy your time on Friday nights at 5:00, and you can have a
Yes.
little wine and other things.
Right.
I mean, medically, if you're able
Yes,
to
yes.
to have it, then you're able to indulge. And I think the quality of life, like I said, more interaction, more people, and if you have the option to choose if you want to be involved or if you don't. And I think the talks of it needs to be more explained, because people just, like I said, everyone just thinks of it. There's like a stigma, like I don't want to put my parents into this facility, but you gotta have to understand: do you have the support, like you said, to maintain them at home or go to an assisted living? So I just think the education behind it and understanding the difference between the assisted living, boarding care, and they all fall under the umbrella of RCFE, but they're not the same.
Right.
The quality of the care that's provided is different and more intimate. So as a physician, how do you prepare them through the tough conversations? Like if they need more care, how do you talk to the family first? Do you talk to the patient? How do you work this?
It all depends on it all depends on the patient's cognition. I start with the patient, but most of the patients that I see where this conversation has to happen can't retain all of that information.
Understood.
So it's a combination, a conversation with the patient, a combination with the adult children.
So
And sometimes it's multiple conversations.
multiple. What happens when there's a conflicting decision?
What's best for the patient?
What's best for the patient?
That's the priority. And the patient's safety.
So even though it's conflicting, this person saying, I want to go home, and you're like, this is not safe for you to go home.
Correct.
And you will over advocate and explain
Yes.
to them what the risk of
Yes.
it is. Of the
This is an
situation.
unsafe discharge.
The-
That's my favorite word.
Have you ever had family that refused to take them to an assisted living and say, I'm taking them home? And then you're like, this is unsafe.
Yes. And I've even had patients who insisted on going home. Family would take them. And I always leave the door open to come back.
Understood.
And I've had people come back sometimes in less than 10 hours.
Absolutely. They send the 8 hours and they realize that this is not it, ma'am. And then
They
you
get
have to
home, the ambulance driver leaves, and they realize they can't get mama or daddy off the sofa
Right.
to take them to the
and there's no
bathroom.
nurse to call.
Right.
So you're like, this is my option. This is what I need to do.
Yes.
So I understood. Okay. Any personal stories from aging adults thriving with the right support?
See, I don't tend to see the thriving side of things.
Understood. You see the ones that are declining. Okay. So how would you prepare for end of life? I think that would be the most suitable question. How do you prepare for someone to have those tough conversations with the family and preparing them that the person has 6 months or less to live emotionally, especially when they're not ready to receive that information? They still have the hopes of
Sure.
of pushing through. And I know it's very difficult because they'll, especially like people with cancer, they're still advocating and pushing through. And you know, as a physician, that they have 6 months or less to live.
Well, first of all, we never really know,
Correct.
but we presume.
Correct.
First of all, with regard to palliative and hospice, those patients tend to be either referred to us by their physician or some other medical professional. But some families who understand about hospice will self-refer, and we do take self-referrals. And we just need to make sure that they meet the criteria. And if they meet the criteria, and we send out usually an admission nurse, usually with a social worker, and they explain what the benefit, what the hospice benefit entails. Some people think that it means that we're going to plant a nurse at your house 24/7.
They do think that, yes.
And we dispel that real quick.
Okay.
And at least in LA County, to my knowledge, I don't know that we have any independent standalone residential hospices. I know that we have, contractual relationships on inpatient units for in-hospital hospice, but I don't know that we have any standalone residential hospices in LA County. So, like I said, the hospice service is provided wherever the patient is located. And so then the nurse and the social worker go out and explain the hospice benefit and get consent from either the patient, if the patient has capacity to make those decisions, or an adult child, or sometimes it's a friend, it's a family friend. Of course, that's where you hope that someone has had the forethought previously to execute an advance directive or durable power of attorney, because then if that person doesn't have capacity, then that designated person would sign the hospice
Paperwork.
Yeah.
So does a person have to be DNR to be on hospice?
They don't have to be.
And you can explain what DNR
Okay.
is.
So DNR means do not resuscitate, which means if your heart stops beating or if you don't have a blood pressure and you stop breathing, we would not perform CPR. You don't have to be. If you meet most criteria to be on hospice, whether you're DNR or not, nature's going to take its course.
Got it.
So, and I have had patients who wanted that full code designation, which is kind of challenging because one has to make shifts in one's brain when certain things arise and have that tough conversation. Okay, you're on hospice. Normally on hospice, we're all about relieving symptoms and providing comfort and not intervening with anything that's artificially life prolonging. You've got this problem here. Normally on hospice, we would make you comfortable. However, because of your designation that you want CPR, I would recommend that we send you to the hospital for this problem that has arisen.
Correct.
And so we have to have that conversation every time. And eventually, I would say probably at least 90% of the patients over time, which also speaks to starting hospice early, because then you have time for people to adjust to the change in their functionality and to really see that the hospice service is there to support them. And but most of them, like I said, about 90% of them will eventually change that designation from what we call full code or yes CPR to no code. And even when they don't, I eventually will start to say things like, I understand what your wishes are. Sometimes it's not really up to us. It's out of our hands.
Right.
A higher power, depending upon what I know about their belief systems,
Understood.
a higher power, or sometimes I just say, nature is going to take its course.
Right.
But
So,
we will honor your wishes.
of course, what if you don't have an advanced healthcare directive? Could you actively work on having an advanced healthcare directive while you're on a hospice?
Yes.
You can.
Yes.
Okay. You could.
As long as you have capacity.
As long as you have capacity, you could work through that.
Yes.
And then palliative care.
Okay.
It's the same benefit, but how does it differ from hospice?
Okay. I like to think of palliative care as sort of like pre-kindergarten
Okay.
or pre-hospice.
Right. Okay.
Okay. You have a condition. Usually it's something like emphysema, cardiac disease. Those are the two big ones. Maybe even some neurodegenerative diseases. And you're likely to live more than 6 months, but eventually you're going to make a shift
Correct.
from an 18 to 24 month prognosis to a less than 6 month prognosis.
Okay. And then palliative care just makes you comfortable.
Well, that and of course monitoring and treatment. So you don't have to be DNR on palliative care.
You do not. So what is the difference? So you can't get physical therapy on palliative care, correct?
You can.
You can.
You can,
Okay.
but it's again, what outcome are we looking for?
Understood.
What outcome are we looking for? And people say that all the time, even with hospice. Oh, you can't order PT because they're on hospice. No. I can order a PT evaluation. The physical therapist can then have a conversation with me to discuss what the needs are. Usually it's for something specific. For example, I can order a PT evaluation for caregiver training for activities of daily living
Got it.
and safe ambulation and transfers.
Okay.
Now, the therapist will evaluate the patient and say, I need 4 or 5 sessions to make sure that the caregiver really can perform things appropriately.
Got it.
That's fine.
That's fine. Okay. I never.
And that's in the patient's best interest because we don't want a caregiver that doesn't know how to safely transfer them.
Correct. And then create an injury.
Exactly.
Okay. So how would you age with dignity before you have any transition to you don't have any need to go to a skilled nursing or assisted living, and the person's aging, they're older, and they're at home living maybe by themselves or with their partner? What would you recommend?
Well, as we all get older, we may have an increased fall risk. Falls are our nemesis. So things like installing safety bars in your home, removing throw rugs. Sometimes you may need to do some remodels to widen certain doorways, particularly if now you may not be 100% independently ambulatory, but maybe you need a walker, but you get along, you get around quite well with your walker. So we just want to make sure that you adjust those kinds of things in your home. Cameras. I actually have a lot of families who the adult children don't necessarily live with their elderly parents, but they have cameras in the home that they can monitor their parents.
They can monitor their parents. So what would be your suggestion if a couple lives alone and they're over 80 years old?
That's hard. It also depends on how vigorous they are, but I'm always worried that okay, so let's say we've got 2 85-year-olds, a husband and wife.
Okay.
If he falls, can she pick him up?
Absolutely not.
Okay.
It'll
You
be two
need a
people
third
falling.
person.
Yes. Okay.
You need a third person,
Right.
or you call 911
Right.
to, for fall assistance. But I kind of think that 80s is that area, unless you're otherwise very rigorous, like your marathon runners
Right.
or mountain climbers, and even then, still, I think it's best to have a third person, either a third person on the property or everybody wearing a life alert so that you can call for help quickly.
What we were discussing is that some people are aging the aging population, we think of 80s, but some people are aging in their 60s or 70s.
Then they need all of that stuff looked at sooner.
Okay.
Yes.
So you're saying it's not basically about the age, it's about where you
It's
are.
about the functionality.
Got it. Okay.
Yes.
So if you see a person declining, or if you see some type of their agility is a little off,
Yes.
you would then say, okay, I think I need a little bit more supervision
Yes.
over
bit
this,
more help.
a little bit more help.
And that's where the communal properties now for the people over 55. That's such a wonderful
Mother-in-law
idea.
suites,
Such a wonderful
the
setting.
ADUs,
Yeah.
Yes, in California. They're encouraging more mother-in-law suites on the property, so then you could have that level of support with the family, especially if you are seeing that they're aging. That's something to consider. Have you had any experience with that, or seeing people do that more often?
I just recently did. Yes.
Okay, can you share a little bit?
Yes.
Yeah. Okay.
Well, mom. Mom had 2 adult children,
Okay.
and one set of adult children, lived off of the property. They converted the garage into the what is it called? The ADU.
Correct.
And mom lived now in the ADU, and the other adult child with their family lived in the
Main house.
main house.
Pretty good idea.
So remember I talked to you about the Dr. Nat rule? So I had a patient a few years back who was 90.
Okay.
And she was mopping the foyer of her condominium.
She lived by herself?
She lived by herself.
Okay.
And she was mopping the foyer of her condominium complex. I don't know why she was doing it instead of a maintenance person, but she slipped
Okay.
and broke her hip.
Oh, no.
They fixed her hip,
Okay.
sent her to rehab. I
Got
was
it.
the rehab overseer doctor,
Okay.
and she did really well. And so as I'm talking to her about her progress and how we can probably discharge you from here in, the next 5 to 7 days, who's at home? And she says, nobody, me. And she was like in her 90s, early 90s. And I felt really uncomfortable with
Did
that.
she have kids, or she was?
I don't remember that. And I'm assuming the answer was probably no.
Got it.
And I think that's where spontaneously the Dr. Sanders rule came into place. That if you're over 80, I don't think you should live alone. And she says, well, I've, been living alone for over
My
10
whole life.
years.
Yeah, right.
But the reason I wanted to tell you this story is because immediately after I walked out of her room, I said to myself, my mother is over 80 and she's living alone.
Really?
And within a week, I called to get some help for my mom. Because when I spontaneously uttered those words to that patient, I thought, ultimately, why am I not doing the same for the person I love most?
Right. It makes you self-reflect because you're like, it puts you into the reality of the situation.
So what we did with the patient, she had funds. So she did go home, and she had a caregiver for about 3 weeks, and eventually let that caregiver go. And I don't know what happened afterwards because I wasn't following her afterwards.
But you strongly suggest to at least have some level of support.
Yes,
After
absolutely.
80, you need to have somebody stay with you.
Yes.
Absolutely. Okay.
I mean, I'm 70. I'm at an age where
very
my
good.
thank you. My fall risk is increased. I probably should have at least a life alert. I live alone, so I should have a life alert. if I fell in my shower and I don't have a phone handy, how am I going to call for help?
Right. Okay. So you have to self-reflect again.
I do.
You're like,
We
I have
all
to
do.
yeah, we do. But for any one of us, if I slipped and fall, I mean, I'm fragile. I could break something, and I
Yeah.
would need to get a hold of it as well.
Yes.
Somebody to help me. So I just think putting that into perspective is a good idea. Okay. Thank you. Okay, as we wrap up today's episode, we want to thank Dr. Natalie for coming out to explain the difference between hospice and palliative care. It was also important she helped us understand how to age with dignity. Thank you for tuning in. Please share with your loved ones that is aging. We will really appreciate it. Thank you.